Welcome to the Lifestyle Medicine Podcast, where my goal is to connect everyday people with health professionals who offer evidence-based advice on disease prevention and utilise science to help you live a healthy and happy life. Dr. Shell, welcome to the Lifestyle Medicine Podcast, mate.
Hello, Andy. Thanks for having me, mate.
It's a pleasure to have you here. Now, full confession, I can't pronounce your entire name, but why don't you give us an introduction to yourself, who you are? You're a urology surgeon, but why don't you tell us a little bit about yourself?
Yeah, of course. So my name's Sheliyan Raveenthiran. Everyone calls me Shell. I am a urology registrar as part of the Urological Society of Australia and New Zealand's program, which is part of the Royal Australian College of Surgeons. I'm midway through my training, 3 years into a 5-year program. I sit my final exam soon. And as part of training, I've been all over the east coast of Australia pretty much, as north as Redcliffe, as south as Wollongong, and everywhere in between, and did some residency beforehand. I've born in Melbourne, raised in Brisbane, went to school out in Ipswich, so I've been a little bit all over the place, and currently I'm working with you, Andy, in Tweed Hospital.
The beautiful Royal Tweed, mate.
Yeah, that's right. Having a great time. So, no, it's a pleasure to be joining you today, and we've got hopefully a good discussion about.
I think we will.
Today.
Yeah, mate. Look, you really painted a good picture of what surgical training, and I think any medical training's about, right? It's pretty tough. You get shipped around left, right, and centre, and just hearing your story, God, being a consultant now and knowing that I'm in the one spot, it gives me shivers. It sends chills down my spine thinking about the amount you've got to do, right? It's hard work, right?
It's hard work, yeah, and you need to be dedicated to it. But look, it's such an enjoyable job, as you know, Andy. We're very fortunate to do what we do, and every day is so enjoyable to work. And part of the movement comes with seeing how different people do things, and you pick up skills along the way, and I think that's very important. So no regrets at this stage, and hopefully only a couple more years of training and they can settle down like you. No
doubt you will, and you'll be here on the Royal Tweed with me. Look, you're right, it's a very humbling job, medicine, and I think it's one of those jobs where you'll never feel comfortable. And even now, as a consultant, past all my training, there's times where I don't feel comfortable at all. And it is very, very enjoyable. So I love everything you just said there, mate.
Yeah. And like you said, Andy, we are in a profession that you almost don't want to feel comfortable, right? Because you start developing habits that might not be, or develop ruts that are not in your patient's best interest. And it's always that feeling of uncomfortability is probably a good thing. It suggests that you still probably care about your job and you're still trying to learn. And that's part of the enjoyment of medicine. I think the fact that you're always learning, you're always picking new things, and you're always getting to learn from seniors like yourselves. And it's part of the journey.
Mate, that is so well said. I think it's spot on. So today, Shell, you'll be known as Shell from here on in. We're going to talk about prostate cancer. You and I see it. I work with you regularly, and you see it more than anyone.
Yeah.
So just for everyone, why don't you just give us a bit of a definition of what is prostate cancer?
Yep. So prostate cancer is cancer of the prostate, and an organ that sits between your urethra and your bladder down in your pelvis. The organ is responsible for the production of semen, and unfortunately, as you get older, that prostate can mutate, and you can develop cancerous cells within. It's fairly common. One of the most common cancers in Australia. Up to 25,000 people a year are diagnosed with prostate cancer, and it's a significant killer of men in Australia. 3,500 people die of prostate cancer every year. So it's more highly diagnosed, or more men are diagnosed with prostate cancer than breast cancer. More men die of prostate cancer than breast cancer, and you can see why there's such an influx of interest into prostate cancer, and why there's so much funding into it, and why there's so much knowledge about it.
Yeah, and it's, I remember at med school they always said that you either die with it or you die from it, right? And most men get it. Is that right?
Well, like you said, Andy, it is a disease of it's ubiquitous in men. Really, if you live long enough, you're almost guaranteed to have it. And they've done studies on cadavers on men who've passed away, and they've diagnosed prostate cancer and a whole host of them. So, like you said, it is something that a lot of people will live with, and And that's why it's so tricky to identify those men that you need to treat and those men that you can leave alone. And I guess we'll be talking about a bit of that down the track as well. But yes, it's heavy burden disease, but a lot of people will have prostate cancer and not have too many problems.
Yeah, well, let's talk about the burden of disease. You sort of touched on that. You're saying three and a half thousand odd men die each year.
Correct. Yeah, 3,500 men a year.
That's just in Australia.
That's just in Australia. Yeah. So it's one of the biggest killers of Australian men. And like I mentioned, 25,000 a year diagnosed with prostate cancer. So a fair chunk of men who are diagnosed will succumb to their disease. But yes, there's a whole host of men that don't as well, and that's why we need to identify those men who are most at risk and pick them up early. Because if we do treat early, like most cancers that we know about, the cure is we can cure disease quite well now with all the interventions that we have available to us, and that's where things like prevention and vigilance with your medical professional are also important to talk about.
Yeah, so I guess what I'm hearing is that it's something that can have pretty devastating effects, and I've seen the effects of it. But we can get on top of it. Is that right? Something that we can really,
100%. Yeah. I think the struggle that that we have, men have, is confronting medical issues. And the good thing about prostate cancer is it can be fairly well diagnosed or fairly well picked up with blood tests and scans and fairly straightforward procedures before we talk about big interventions and things like that. So we've moved away from diagnosing men with prostate cancer when they rocked up at the hospital with metastatic disease, which was only as recently as in the 80s and 90s. We'll talk about the PSA test, but that was all fairly new thing. So that doesn't happen as much anymore, thankfully. But like I mentioned, there's still a whole host of men are still passing away from the disease, and cure is better than, or prevention is better than cure, but cure is better than,
cure is better than no cure.
Exactly.
Yeah.
Exactly right.
So you're saying that most of these people used to show up with advanced metastatic cancer.
Correct.
Let's talk about natural progression. Yeah. It starts localized, like any cancer, and then where do we go to from there?
Yeah. So men develop prostate cancer predominantly in the peripheral zones of the prostate, the outside portions of the prostate, which is important when we talk about symptomatology down the track. But organ confined disease, like I mentioned, is we've got good treatments for it, and we've got good cure rates for it. The next step after it escapes from the prostate is it travels to little organs that sit behind the prostate, which are called the seminal vesicles, or they can invade outside of the prostate into your bladder or your rectum or your urethra, all the organs down in your pelvis. They can also metastasize or spread to other parts of your body. Usually goes to your lymph nodes in right at the back that sit next to your large vessels in your back, before usually going on to the bones. And that's usually previously that's how men would present. They would come to the hospital with pain in their spine or pain in their legs, and without any other symptoms, and they would do a CT scan or a bone scan, and they would light up. They'd have cancer all over the body. And by that stage, once it's escaped your prostate, cancer is invariably terminal. It's not curative, and management's all about life prolonging measures. Very rarely does prostate cancer go into your visceral organs, your liver, your lungs, those kinds of things. It can happen, but more often than not, it's usually to your lymph nodes and your bones, and then progresses from there.
Yeah, you really struck a note with me there. We have a family member who presented with back pain and was metastases from prostate cancer, and it's a horrific thing. Yeah. It's just, like I said to you before, we're such good disease professionals. We see disease all the time. We see it every day, and it's mind-boggling when I see people who would rather choose. It's not that people choose that, but people just neglect their health, and then these things happen. It blows my mind away. So,
and I think, Andy, it's maybe not so much, or maybe it is a neglect of health, but maybe it's a lack of knowledge as well. It's
great point.
Fair to, like, we're very lucky in that we learn about this stuff. We see it on a day-to-day basis, but men and women around Australia probably just don't know, or don't have the knowledge, or don't have the access to knowledge that we have to know how important preventative healthcare is. And we'd prefer to have no patients really in an ideal world. If we were not busy at all, that would be great. But it's the fact that people just don't have the knowledge or the capabilities or the access to healthcare that we're so fortunate to have. And that's why this is so important.
Oh, mate, thanks for bringing that up. That was perfect. Yeah, you're 100% spot on. So, in saying all that, then what are the signs and symptoms? What should blokes be looking out for?
Yeah, and like I said, most men. I was in clinic today. I saw, of the 20 patients I saw, probably half of them were for reasons related to prostate cancer, and 3 or 4 of them were new diagnoses. And invariably, most men will come to my rooms having had a PSA test with their GP. And you'll ask them, why have you presented today? And they'll say, I have no idea. My GP's done a blood test and they've sent me in. So invariably, most men will present with no symptoms. And that's why with most cancers, which is it's similar, by the time you develop symptoms of your cancer, it's probably a bit too late, or in some instances. So, and prostate cancer is definitely one of those. By the time you develop issues with your waterworks or back pain, like we mentioned, it's invariably quite locally advanced disease or metastasized. Like I mentioned, cancer usually grows in the outsides of your prostate, which is well outside of the tube that runs within your prostate, which is your urethra. And if the prostate cancer doesn't compress on where you pee through, you're not going to have any issues with your waterworks. Usually, if you have problems with your waterworks, it's due to other benign causes of prostate enlargement, and that's majority of what we do. Yes, but cancer usually grows on the outside, and most men will come and see me with very little symptoms. That being said, others will present with issues with their waterworks or blood in their urine, and locally advanced disease. They'll block off their kidneys and they'll come back with pain in their kidneys, or kidney tests that suggest that the kidneys are not working as well. And we spoke about already the fact that disease can spread to your bones, and men can present with that as their first presentation to the hospital as well.
Yeah. And you just to define some terms there, you mentioned benign prostatic hyperplasia.
Yeah.
That's a non-cancerous condition. Correct. Do you want to just quickly explain what BPH is for the listeners?
So, like you've mentioned, and it's in the name, benign prostatic hyperplasia is growth of the prostate in a benign fashion. So as you grow older, all men's prostates will grow. Your benign tissue will grow as well as potentially your cancerous tissues will grow, and it's the benign tissue that invariably causes the issues that men present with respect to their urinary problems. And that's because benign tissue usually grows closer to the urethra, closer to the center of the prostate, and causes obstruction of the prostate. And that's when patients will come in and tell us, I'm finding it difficult to start urinating, or my stream is very, very weak. I can't pee like I did when I was 20. I don't know what's going on. Or I'm not completely emptying my bladder, or I'm getting quite urgent, or those are the kinds of symptoms patients will present with when they've got issues with their voiding. And that's, sometimes that's a reassuring thing, because you think to yourself, it's probably a benign issue here that I'm dealing with. Obviously, there are exceptions to the rule, but it's fairly benign pathology, that, and we've got lots of treatments for that, which is a completely different discussion to have. But in terms of benign prostatic hyperplasia, that's a condition that most men will develop in their lifetime, and we see a whole host of patients with that condition.
As a side note, I remember being in the men's change rooms with one of the urology consultants, and I'm not sure if the listeners want to hear this, but one of the operations assistants was going to the toilet, and the urologist said, "Mate, that stream doesn't sound too good. You might want to get your prostate checked." So I know what urology
based on the toilet findings. Yeah, and that's part of what we do. There's those and you can definitely pick up those that you're going to be seeing in your clinic very soon. But look, it's a problem that men have, and again, it's almost impossible to avoid, and most men will develop issues with their stream at some stage and see a urologist in their lifetime. But that, like I said, is benign, not cancerous growth, and very treatable. That.
Yeah. So let's talk about screening. And you mentioned obviously PSA and things like that. How do we screen for prostate cancer?
Yeah. I guess we should start that conversation by saying that screening is quite a controversial topic. Urologists and primary healthcare physicians, GPs in the country, probably have differing views on how patients should be appropriately screened. Obviously, we see a very select cohort of patients who all have or invariably have some prostate cancer, whereas general practitioners work with the majority of the patients who don't, and will have issues that are completely unrelated to prostate cancer. And that's why there's a bit of a conflict in how we view screening.
And this is just highlights the nuance of science. Correct. As well, right?
Correct.
There's times where we just don't know 100% every time and I think this is what the general population, you've really highlighted an important point. General population don't understand. They think, well, how can there be so much a discrepancy? Yeah. We're doing the very best we can with the information we got, right?
Correct. Yes, and you will see. It's a difficult conversation to have with some patients who think that they've been referred too late or too early, because the guidelines, we follow guidelines and GPs follow their own. In fact, I don't think it's part of their guidelines to do routine PSA screening on all men. And it requires, informed consent about what it involves and treatments and all the rest of it, which is a tough conversation to have in a 10-minute or 5-minute consult in a GP practice when it's such an easy thing to just add on a blood test. And that's why we need to be having these conversations more public, so people have a bit of knowledge before they walk into their GP practice and request tests and talk about how best to investigate things. But PSA has been a game changer for prostate cancer. Like I said, I think 1991 or something like that was when it was first introduced in Australia. Prior to that, men weren't diagnosed with prostate cancer unless they presented to the hospital with metastatic disease. And ever since then, we've been able to pick up disease much sooner and cure a lot of men with prostate cancer. But as you know, Andy, the issues with any kind of treatment in medicine is that it comes with risks and side effects, and that's where we're trying to weigh up, the risks of treatment versus the risks of overdiagnosis and overtreatment, and that's where we've gotten a lot better than we used to be. We did used to treat a lot of cancer that may not have caused patients harm in the future, but with newer technology, that's become less and less of a problem. But I think because of those issues in the past, we've had some difficulty with organizing or making screening more available to all men, but hopefully that changes with time as our technology gets better and as we get better at interpreting imaging and biopsies and all the rest of it.
Yeah, we're constantly adjusting, right? I've had this conversation with you before. There was a book I read, The Organised Mind, by a guy called Daniel Levitin, who spoke about, he spoke to a urologist and he was sort of talking about the risks of dying from prostate cancer versus the risk of dying from the procedures and the testing and the treatment and all the issues. And we constantly weigh up. That's our job every day. We weigh up the risks of not doing anything and the risks of doing something. And we're constantly evaluating that data, and we reevaluate it, and we look at it again, and we look at it again and again and again. And then we come up with a bit of a consensus, and we get a whole heap of people to come up with consensus guidelines. We go, okay, well, this is not 100% the best way to do it.
Yes.
But on a probability basis,
yeah,
that's how we operate. Your probability of having a successful outcome with this surgery is far better, if we do it this way. So I think you've highlighted a great point. There is harms to doing everything. And it's like, if we do a PSA on someone and we find prostate cancer, we used to take out their prostate, they had lots of problems. But
Correct. Yeah.
Nowadays, we pick the right patient, right?
Correct. Where our patient selection is much better than it used to be. Our techniques and how we do operations and radiotherapy and all the other medical therapies that we have for prostate cancer are evolving every day. Prostate cancer is one of those conditions, thankfully, that has a lot of funding. It's well known about. There's lots of funding. There's lots of organizations. There's lots of research, and Australia is one of the pioneers in that field. And that just means better results for patients. So yes, it's been controversial. Yes, it will continue to be controversial, but rest assured that everything's being done with patients' interests in mind and trying to improve patient outcomes. But if we talk about PSA as a blood test, many of your viewers might not know, it's a fairly straightforward blood test. PSA stands for prostate-specific antigen. It's a protein that's produced only by the prostate in the body. I think we've spoken about the the issues with PSA as a screening tool, primarily because PSA isn't just related to cancer. It can be elevated for any number of reasons: infection, inflammation, trauma, benign enlargement of your prostate. We spoke about before BPH. That can also increase your your PSA levels. So prostate cancer is only one of the things that that can result in an elevation in your PSA. So
and the body's secreting it naturally as well,
correct,
like at low levels, right? Yeah.
Yeah, your prostate's always secreting a bit of PSA, and those levels can fluctuate with time. So when we talk about PSA as medical professionals, we don't, and lots of men will come up to me and say, "Oh, what's your cutoff PSA before I know I've got cancer?" And to be honest, there is no cutoff. We have men who have a PSA of 1 who have prostate cancer. We have men with a PSA of 30 or 40 who don't have prostate cancer. It's not just the single number that defines or diagnoses you with prostate cancer. It's a trend over time. And that's why we recommend surveillance, because we can get an idea of what your normal levels are and what is abnormal for you. For example, your PSA might be normal at about 0.5 or 0.6. And if it jumps up to 2 or 3, that may be concerning for you. Whereas another man might have a big prostate or has an infection, his PSA's in the 10s or the 15s, and that might be normal for them. And if they increase to 20 or 30, it might not mean cancer. It might just be a process that they're dealing with. So it's not just a one size fits all. And I think that's probably a little bit difficult for some patients to grasp. It's not just it's not binary. It's not 0 or 1. It's not, yes, you've got prostate cancer, or no, you don't. It's a trend over time. And like you said, it's the nuance of trying to define what's concerning that is up for debate, and that's why PSA can be considered not always the best test in determining things.
Yeah. All right. Well, let's just take a wide angle here and have just look at everything from afar. Yeah. So, if I'm a patient, if I'm a person, I'm 38 now, 38 years young. Yeah. What age do I start screening? And when I go to the GP, what do I talk to my GP about?
And that's a good question. So the USANS, the Urological Society of Australia and New Zealand, our recommendations are to commence PSA surveillance from 50 years old till about 79 years old. With no risk factors, we would recommend a PSA test every couple of years during that period, 50, 52, 54, and so on and so forth. In those men who have elevated risk of prostate cancer, those with a family history of disease, we recommend screening to start earlier, from your 40s, because prostate cancer, family history of prostate cancer, is one of the biggest risk factors for developing it in the future. Though invariably most men don't have family history as a risk factor, but it's one that we know about, and we do recommend screening from an earlier age as a result of that. There are lots of adjuncts to a simple PSA blood test. They talk about free to total ratios. They talk about PSA velocity. There's lots of little things you can do with your PSA test that urologists look at to help us determine whether or not you have an increased risk of having a malignant or a cancer or not. But usually it's based on serial blood tests over a period of time to give us a better idea of what's going on.
Right. And so PSA is the only screening tool, a tech tool at this?
At the moment, yeah. And obviously our recommendations are for a clinical examination, because oftentimes men will have very benign or low levels of PSA, as we've mentioned, but may have a clinically significant or something that we can feel with our fingers, prostate cancer. And every man that I see in my clinic, unfortunately, gets a digital rectal examination.
I was just going to say, can you clarify what clinical exam is for everyone? But I'm glad you've clarified that.
Not many men, surprisingly, will still be surprised when they come to our offices and we tell them, we need to do a rectal examination to feel your prostate. And look, we've all diagnosed many men with prostate cancer simply based on what we can feel on our fingers, rather than what a blood test shows us. So it's still a very critical step for diagnosis of prostate cancer and benign change of the prostate. And that, coupled with your PSA screening, gives us a bit of an idea of which men are likely to have an underlying cancer.
Yep. So how do we diagnose it then from there?
Yeah, good question. So say, I'll give you an example of a patient, a 55 or 60-year-old man comes in, his PSA is a little bit elevated. I do a rectal examination on him. He's got what feels like a cancer in his prostate. Traditionally, what we'd usually do at this stage is book them for a biopsy, a prostate biopsy. But in Australia, since 2018, we've had MRI scans funded by the government, which help us, which give us a lot more detail about what's going on with the prostate. So that's funded by the government. If you meet some criteria, you need 2 tests within 3 months, and you need to be of a certain age and have certain levels. But it's a great test that costs a bit of money. That's well funded by the government, and we're all very thankful for that. Based on the MRI test, we're able to identify areas within the prostate which may be concerning and may be harboring a prostate cancer. It's not a diagnosis based on the MRI. It's just a suggestion that there may be something there. Okay, and we or the radiologists grade the likelihood of developing or having a cancer within your prostate from a grade from 1 to 5. 5 being the highest likelihood of there being something within your prostate, 1 or 2 being very low likelihood of something being in your prostate. And based on the clinical, the PSA, the clinical examination or a rectal examination and your MRI, we then discuss a prostate biopsy as the definitive way of diagnosing men with prostate cancer. Prostate biopsies, as you've seen, Andy, are fairly straightforward procedures. They take about 20 or 30 minutes. Patients are put to sleep in Australia. In some other countries, these procedures are done in rooms under a local anesthetic. And I think that's how most of America does it. But it's fairly straightforward. We take biopsies of the prostate through the skin underneath the scrotum. So you end up with a few needle marks in your skin. And you go home the same day. You can have some blood in your urine afterwards. You can get some blood in your semen afterwards. You can find it a little bit difficult to pee for a few days. But most men tolerate the operation well and come and see us in rooms a couple of weeks later to talk about the results of the biopsy. And the MRI helps us guide where we target those needles. But we also always do a random sampling throughout your prostate as well, because prostate cancer has a tendency to be multifocal or in multiple locations within your prostate, not just one. So we usually will target any areas on your MRI, but then we'll do a sample throughout your prostate systematically just to make sure we're not missing anything.
Well, now that I know you can do it under local anaesthetic, I might have to start showing up to work a bit later, and that way I can go and have a coffee.
Yeah,
but,
exactly
just
right.
let the cat out of the bag there. Alrighty, so let's talk risk factors. So you mentioned family history.
Yeah.
I'm going to say smoking for sure.
Yeah.
Anything else? What are the big ones that people should worry about?
Look, it's one of those diseases that, despite having a lot of money and funding and things like that, we don't have a clear grasp of all the environmental risk factors that can lead you to develop prostate cancer. We know for sure that family history does. Genetics, men and women who have a family history of things like breast cancer have the BRCA gene, as I'm sure most of your viewers have probably heard about, that can increase your risk of things like prostate cancer. So we do ask that pointedly. And then, like you said, smoking has been shown to have some weak correlation with prostate cancer as well. But it's one of those diseases, unfortunately, that most men will develop in their lifetime. And it's not much you can do to try to prevent yourself from getting it, apart from being quite vigilant with your healthcare and diagnosing things early and seeking treatment appropriately.
Right. So BRCA gene was fascinating. I've only ever really heard that in terms of breast cancer in women.
Yes.
But we essentially can test for it in men too.
Yeah,
it's a risk factor.
Correct.
Yeah,
So
right.
BRCA1, BRCA2 are both risk factors for prostate cancer. And that will pique our interest a little bit if we have men who come to the rooms with family members who have developed prostate or breast cancer and we test at lower levels of PSA for malignancies in those men. So yeah, it's one of those strange ones that there's a relationship between the two.
Right. So we've essentially walked through everything to this point. You've seen this patient in your clinic. you've done the digital rectal examination, much to their disgust, and the PSA is elevated, and you've done the biopsy, and it's prostate cancer. What's the treatment from there? I'm assuming it's going to depend on a few things.
Correct. Yeah. So treatment's entirely dependent on the aggressiveness of your cancer, essentially. And the second question is where it is in your body. So as most cancers are, the histology or pathology doctors look under the microscope and give us a reading on how aggressive your disease is, low risk, intermediate risk, high risk disease. And dependent on that will depend on what kind of management you get. So previously, any kind of prostate cancer we would treat quite aggressively, even low risk cancer. And now we know with more experience in the field and longitudinal information and data, following men over a long period of time who've got the disease, we realize that low risk prostate cancer is one that we can safely watch and still offer curative treatment to men who may progress later down the track. So oftentimes more men are being watched in what we call active surveillance, rather than having definitive treatment with either surgery or radiotherapy. And that's a completely safe option in men with low risk disease or low volume disease in their prostate. So that's the important thing to identify. Active surveillance is a fairly new phenomenon in prostate cancer, certainly not practiced to 100% yet throughout the world, but we're getting better and better at identifying the men who need treatment and those who we can watch safely.
Yeah, and what does it involve? Is it DRE, PSA?
Yeah, and much of the same is how we initially diagnose prostate cancer. So, like you said, it's a PSA test, it's a DRE. We usually do.
And just for everyone, DRE, digital rectal examination. Yeah. Sorry, I probably should. Throw around medical jargon.
Finger up the bottom. Yes, exactly. So. We do those investigations every 6 months, 3 to 6 months usually. We usually repeat your MRI test at a year, which is, again, government funded, to see if there's any progress in those lesions that you may have had on your original MRI of your prostate. And then we usually perform another confirmatory biopsy of your prostate at about 1 year's time, another one of those biopsies. And the reason is, as most biopsies are, we are only taking a sample of tissue that's very small from your prostate, 1 or 2 centimeters long, but 1 or 2 millimeters wide, very, very small size of your size of tissue. And to put that into context, a normal prostate's about 15 to 20 grams. Most men we see in our clinics have prostates anywhere between 50 and 100 grams. So we're talking about very, very minuscule amounts of tissue that we're taking biopsies off. And there's always a chance that we may miss disease in your prostate. Hence why we do the MRI again and make sure we don't miss cancer on that second biopsy, or we don't upstage it to something a bit more aggressive and needs treatment. But assuming at that year, that re-biopsy in a year's time, you still have disease that's, under control or, very low risk disease, we just continue watching you well into the future. And we just extend the periods of your surveillance out. So you might go out to a 6-monthly PSA and a rectal examination, to a yearly one. We usually do another MRI and a biopsy in about 2 to 3 years after your second biopsy. And then we just follow you moving forward. And the whole premise is trying to delay treatment or even avoid treatment for as long as possible, but still offer men the option for curative management. So if at any stage your PSA starts to climb or your biopsy suggests that your disease is progressing, we have all the options on the table to still treat and cure men with prostate cancer.
Yeah, and that's a classic example of how we've adapted to the science and to the data that we've received, right? We can see that, yes, there is significant risk with medical intervention, and a lot of people, I think, tend to I see negative press all the time. It's always a negativity bias, and you think, doctors do this and they do that, and they're doing the wrong things. Well, we very much try to avoid doing anything if we possibly can, and I think that's a great point.
Do no harm, isn't that what we're always?
Yeah, exactly. So from there, watchful waiting or active surveillance is what's the appropriate term.
Yeah.
What are the next options after that?
Yeah. So active surveillance is number one. Number two, if you've got cancer that's aggressive enough that we think you need treatment, we talk about definitive management with either surgery or radiotherapy. And the important thing to know about both of those options is they both offer the same cure. One is not better than the other. And we know that based on longitudinal research. This is not, surgery is not better. I'm a urologist. I'm supposed to say surgery is better, but it offers the same cure rates as radiotherapy. So the issues have got to do with the side effect profiles of both surgery versus radiotherapy. Surgery is, depending on how you do the operation, it's either an open cut, laparoscopically, or keyhole surgery, or we've got robots now in some hospitals that we can do the operation of. Important to know that no matter which way you have the operation, the outcomes are the same oncologically, or cancer outcomes are the same, whether you have a robot operation or an open operation. The cancer is removed at the same rate. Your functional outcomes, your ability to urinate afterwards, your erections, all of that are the same. It's just a different modality of doing the operation. And more people are having robotic operations as it becomes more in vogue and more popular and more available. But at the end of the day, the operations no matter which way you get the operation done, it offers the same kind of outcomes. And that's been proven here in Brisbane, actually, in Australia. That was a massive study out of the Royal Brisbane Women's Hospital, where they compared an open operation to a robotic operation and showed that the outcomes were exactly the same. So
yeah, so is the robot then? I guess it's less invasive. There's less cutting. There's less scarring.
Yeah.
And what about recovery post-op and things like that?
Good question. So I guess the question is how many people know about what a robot is. It's not like a robot that's under its own control doing its own operation. It's under the command of urologists in the operating theatre. It's done very much like a laparoscopic or keyhole operation. You have ports in your belly, and it's just that the robot is a little bit more finer with the movements and things like that. You get good vision with your robot. Like you said, bleeding is a little bit less. We do know that from research. The risk of bleeding is less. The risk of needing a transfusion or a blood replacement is less. And yes, operative time is about the same, but going home is a bit quicker. Right. Most men who have a robot operation are out the door sometimes the next day or the day after that in 1 or 2 days. Whereas with an open operation, you can expect to be in hospital for about 2 to 3 days, which is pretty average in most cohorts. But then, like you said, moving on to 4 to 6 weeks down the track, obviously with an open operation, it's a bit more of a recovery period, and you need to take it easy a bit longer. Whereas your robot patients who have their robot operations recover a bit quicker and are back to working and things like that, maybe within 2 to 4 weeks rather than 4 to 6 weeks with an open operation.
Right. Yeah, I've seen many operations. I've seen your team in action many times, and it is a very significant procedure.
Yep.
And you can get desensitized to surgery sometimes, but for someone seeing what has to happen, it can be it's amazing, and to see to not blow smoke too far up there, but no, what you guys, credit where credit's due. I think it's fantastic to see what you guys do. It's just really a incredibly technical procedure. It's just amazing that we have access to that, right?
Oh, for sure. And I guess the question is, what exactly do we do? It is a big operation, but what are we operating 4 hours? What are we achieving in that time? And essentially what we're doing is you have your urethra where you pee from, you've got your prostate in the middle, and your bladder on the outside behind your prostate. Essentially what we're doing is removing your prostate and sewing up your bladder to your urethra and connecting everything in between. That's essentially the premise of the operation. And trying not to damage structures that surround that whole area as well. After the operation, you end up with a catheter or a tube that goes into your bladder, and that stays in for about 10 days time. And at that 10-day mark, we take your catheter out and you're peeing after that. And then we see you in about 6 to 8 weeks down the track with a PSA test to see if you've got any prostate cells lying around in your body still. Right. So in terms of risks, infection, bleeding, damage to any of the structures that are surrounding the prostate, those are the common things that anyone associates with surgery. anesthetic risks we also mentioned, and obviously anesthesia is much, much safer than it was 100 years ago, and the complications of anesthesia are fairly limited with respect to our patient cohort, at least.
Yeah, I totally agree.
But
And I guess erectile dysfunction is something that's probably pretty big for a lot of men too, right?
Exactly. So we have the immediate complications of surgery, then we look at the medium and the long-term complication of surgery.
Yeah.
Two that we always talk about are incontinence and erectile dysfunction. So incontinence, where you're wetting yourself with no control over how you urinate, is a fairly rare complication of surgery. We talk about a 1 in 20 risk of men needing an incontinence pad at about 1 year after the operation. So 5% risk, 5 to 10% risk of needing a safety pad. Most men, when I see them at the 2-month mark, they're invariably dry. They will have full control over their waterworks. They wear a pad for safety. So it's just a safety measure, something that gives them a bit of comfort that if they do have a leak, there's a pad there. And the important thing about that is making sure your pelvic floor muscles are nice and strong before you have the operation. And we always refer our patients to physios to strengthen that with Kegel exercise, all the rest of it. You're right. And then we continue that after the operation as well. So that's a fairly, it's a risk known to surgery, but we're getting better and better at trying to avoid that complication. And then, like you said, erectile dysfunction, and that is a much more common risk with surgery. And that's simply because the nerves that supply your erections travel all around your prostate. And at the end of the day, the goal of surgical management of prostate cancer is, number 1, getting rid of all the prostate and curing you of your cancer. Number 2, making sure you're continent of urine. And number 3, trying to preserve some erectile function. And we do have better techniques at preserving erectile function. For example, if your cancer on the biopsies and the scan seems to be only on one side of the prostate, we can try to preserve some nerves on the opposite side and vice versa. But at the end of the day, it's a cancer operation. And at times, men will lose their erections as a result of surgery.
Yeah, and I guess you got to kind of weigh up what's more important to you, I guess.
Yeah, exactly. Yeah. And, there are things you can do before to try to improve your erectile function afterwards. But at the end of the day, we're not going to make your erections better than they were before your operation. In fact, it's almost likely that it's going to be worse. And, erectile dysfunction, very, very common problem in men as young as 30. I see men in clinic who come in saying, I have issues with my erections in their 30s. So it's not an uncommon issue. There's lots of preventative things you can do to try to avoid those erectile function issues. And if you're going into an operation with strong erections, then you have the best chance of coming out of an operation with erections as well.
Yeah, right. So you did mention radiotherapy as well, and is that a viable option for people as well?
100% it is. Yeah. So so when we talk about radiation, that's supplied by our colleagues, radiation oncology colleagues. It's usually a course of treatment for 4 to 6 weeks, daily, Monday to Friday for that period of time. They usually perform external radiation. Look, just a disclaimer, I'm not a radiation oncologist. This is my understanding of how radiation is given and how it's performed in Australia, but it's external beam radiation. There are other methods of doing it. You can put radioactive seeds and rods into the prostate, but they're becoming less and less in vogue. It's usually the external beam therapy that's becoming more accepted in practice, certainly in Australia. And like I said, 4 to 6 weeks of treatment, and then we usually carry on your surveillance moving forward after that with regular PSA tests and the rest. And men with radiation typically tolerate the radiation fairly well. They can have some issues with their waterworks, they can have some issues with bowel motions, they can have issues with erections as well, but typically they get through the course of treatment pretty well. The issues with radiation we usually see down the track, 5 to 10 years down the track as a result of radiation changes that occur in and around the prostate, or the scatter that occurs in the organs that surround the prostate. So If you have radiation that scatters into your bladder or your rectum or your urethra, your pipe where you pee from, you can get bleeding, you can get narrowings, you can get fibrosis or scar tissue. You can get risk of secondary malignancies or other cancers popping up in those other organs as well. So there are, those delayed side effects are there, and we see them less regularly than we used to see them. That's for sure, as radiation therapy's gotten better and better. But they're difficult problems to fix if and when they develop, and that's why in our experience as urologists, most men who are on the younger side usually choose to have an operation, whereas those men who are a little bit older and have other medical issues that put them at risk of having complications as a result of surgery, they usually opt for radiation treatment. But like I mentioned at the beginning, both options are viable options that offer the same cure rates, and they're both very feasible. And we do recommend all patients seek, an opinion from a radiation oncologist before they opt for a management principle that they'd like to decide on.
Yeah, I think you've just really highlighted how complex healthcare is, or disease care, whatever you want to call it. And it's so important to be able to sit down with someone like yourself or anyone who has context to apply to that situation, who can look at everything in its entirety. And then it must be so hard to just explain that to someone who just comes in with no background and just goes, what do you mean I've got to do all this? It's just super overwhelming. And I guess that's the whole point of these podcasts, is to try and help communicate that to the general public.
And Andy, it's such a, we've been speaking now for 20 odd, 30 odd minutes, and, we're trying to grasp the complexity of prostate cancer. And how do you have this conversation with a man in a clinic room as a GP and help them understand what we've been talking about? It's so complex, on top of all the other medical issues that patient in front of you presents with. It's so difficult to have a conversation about the risks and benefits of PSA surveillance and testing and which men should have it. And it's so much easier in some instances just to do a PSA test and send them off to a urologist and trust that your urology colleague will manage this patient appropriately. And I think that's the struggle that we all have. No one has the time to be getting all this information, or to have this information in a palatable fashion where you can understand what's going on, to make an informed decision. And that's all medicine is, having all the tools in your armory to make an informed decision for yourself about what's best for you and what you prefer not to have. And that's where, these podcasts are so important, because you need to convey that message in a friendly manner, and help people make decisions that are best for them.
Oh, I totally agree, mate. And as you know, in medicine, we're moving away from that really paternalistic approach and of just, doctor knows best, do what the doctor says. But there's times where I feel like it must be so hard for people to make an informed decision. And how they even can comprehend any of the side effects. I sit there and I think about some of the times I'm consenting women for epidurals who are in labour. They're just like, mate, just put the bloody epidural in, shut up. Take the pain away. And you just, people don't really understand the side effects of things sometimes. So it is really hard.
And that's why you're putting a lot of trust in your medical health professionals, and you're hoping that and we do practice in a way that's in your best interests. And yes, we talk about informed consent, and it's so difficult to define what informed consent is in this day and age, and how much information do you need to give informed consent. But emergency consent's different to what we do in a clinic setting and all the rest of it. But at the end of the day, information is power, and the more information our patients can have to make a decision that's best for them, the more important than the best it is for them.
Yeah, you're right. So let's bring it home to the final point: prevention. How do we prevent this? We talked about this before. Lifestyle. What are the main things? I'm going to say avoid smoking.
Yes,
it's going to be a big thing. Is there anything else? Is there anything else we should be doing?
Keep a healthy lifestyle, and I think for men in particular, it's being vigilant with your healthcare. it's women are so much better than us.
Oh yeah, we are terrible.
We are shocking, and you can see it based on when men come into your rooms and you ask them why you're here. They have no idea why they're there. They tell you, oh, it's in the referral letter.
Most of the time, it's their wife who's there dragging them in.
100%, and invariably the wife's in tip-top condition, never had any health problems in their life, and the husband's there just clueless as to what's going on.
Yeah.
It's just, and it is the way men are, I guess, but it's at your detriment. Not being, not leading a healthy lifestyle, not going to your GP regularly, not getting blood tests when you should, not getting examined when you should. Those are all gonna bite you down the track at some stage, and I think that's the most important thing, especially with prostate cancer. In terms of prevention, there's probably not too much you can do at this stage to prevent, or apart from being vigilant with your healthcare and making sure you have a good relationship with your GP and following through effectively and regularly, and that's what we would strongly recommend.
Yeah, and what about obesity? Is it associated with it at
all?
Is it something?
Strangely enough, there's some research that suggests it's protective. So that's
wow.
That's the thing. We'll have to.
Yeah.
That's the thing with a lot of research. You can, as you know, Andy, you can twist research to say what you want it to say in different ways, and you have to be careful with how you conduct studies and what the primary goals and aims of studies are, and what is a correlation or what's related to prostate cancer and what causes prostate cancer, two completely different things. And that, I guess that's where it becomes quite difficult to know what exactly causes it, as opposed to other conditions that we know strongly. In the urology space, we know that smoking almost is one of the strongest risk factors for bladder cancer. If you smoke, the only men and women I usually see with bladder cancer are those who have smoked in their lifetime. So as opposed to things like prostate cancer, where you will see completely fit, healthy men who've led a very healthy lifestyle, and have just, have a family history for it. Their father or their brother has had it, and they come in with a PSA that's elevated, and unfortunately they have prostate cancer. So it's one of those diseases, unfortunately, that there's not too much you can do apart from, keeping as healthy as you can, to get you through management processes that you may need in the future, but more importantly to keep tabs with your GP and making sure you're being investigated properly and early.
Yeah, that makes sense. And we talked a little bit about diet.
Yes.
I read a small body of evidence to suggest dairy. I think obviously the mechanism is it's the insulin-like growth factor in dairy, but again, it's what are your thoughts on that? Have you looked into that?
I agree, Andy. I think there is growing research in that field, and it's fairly new. I saw a couple of systematic reviews and meta-analysis, which are just a whole bunch of studies piled together, and they look at results and try to make some overarching conclusions based on multiple studies. And there is suggestion that there might be a relationship, but again, I guess the question is it a correlation? Are they related, or is one causing the other? And I think that's where we are still at the space where we need to work out. And the only way you work problems like that out are having a cohort of men who have had lots of dairy in their lifetime and cohort of men who don't, and trying to work out if there's a relationship, assuming that all other factors between the men are completely the same. So that's probably a difficult study to do.
Incredibly difficult. Yeah.
But there is some new research that suggests that there might be a relationship. But in terms of how much is too much dairy, how much milk is too much milk, I wouldn't have an answer for that. And, I wouldn't want to tell men watching this podcast to go straight off milk because of the off chance that they may develop prostate cancer. It's still a very important commodity and produces, gives you calcium and all the rest of it. But at this stage, it's very, very much in the wait and see kind of space.
Yeah. And there's so much like this, right? Research has to start somewhere.
Yeah,
exactly. And that's the important part. So, all right, mate. Well, let's wrap this up. Let's just summarize, I guess, the main points. So, age for screening. You said 40 years old if you have high risk. Is that right?
Yeah. Yeah, and risk would be a family member with prostate cancer, father, brother more higher risk than a father, uncles, those kinds of risks. We would recommend, or the Urological Society of Australia and New Zealand would recommend starting PSA surveillance from 40 years old and continuing that regularly until you're about 79. The reason we say 79, and I guess we didn't really touch on the natural progression so much, is that if we left prostate cancer alone in elderly men who are diagnosed, you have a life expectancy of 7 to 10 years if we did very little. So if you're in your 70s, late 70s to 80s, and you have a whole host of medical problems, and you come in carrying a A4 size paper with 20 drugs on it, there's a good chance something else will take you before your prostate cancer does. And that's where the saying comes, most men die with it rather than of it, because it's usually a disease of elderly men or men who are a little bit older, majority, and diagnosing and treating prostate cancer in men in their 80s who've got dodgy hearts and lungs and kidneys is doing them more harm than good, because there's a good chance that the prostate cancer is not the primary concern in them. So, that's why we recommend surveillance till about 79. So 50 to 79 or 40 to 79, and then a discussion with your GP for continuing surveillance further than that if you think it's appropriate. And that's for very fit and healthy men who have no issues with their health and are likely to live well into their 90s and all the rest of it. Then there may be some utility. A PSA after that, if it's super high, may tell us other things, but that's the recommendations.
Yeah, and we certainly don't want to be anaesthetising people over the age of 90 for a radical prostatectomy. Their anaesthetic risk is sky high, so we can stop testing. And like you said, so 40 if you've got risk factors, 50 if you don't have risk factors, up to the age of 79, you're getting a PSA by your GP, and you're getting your finger in your bottom. That's a digital rectal examination. Correct. I heard you say finger in the bottom before. Correct. That's about as clear as it gets. In terms of risk, obviously smoking and just live a healthy lifestyle. Do everything you can. But again, the science is pretty inconsistent. Treatment wise, watchful waiting or active surveillance is probably very likely for a lot of people. But then we have fantastic surgical techniques and also radiation therapy.
Correct, exactly right.
Shell, this has been awesome, mate. I really think it just epitomizes, like what we were saying before, how complex these discussions are. And my hope with these podcasts is that someone can sit down on their day off and just go through it and listen and just, become more educated on something that is incredibly nuanced, incredibly complex, but just be able to hear it from people who know what they're talking about. And I think, like you said, you said it before, people tend to get different answers from various people. There's no consensus on PSA, when it should be done and things like that. And we all bring a host of biases and our own personal experiences, and your biases will come from what bosses you had during your training and what they did. So it's really
that you see as well. Exactly. Like you'll see 50-year-old men who have prostate cancer and you think, oh, I wish we'd started surveillance earlier. But then you'll also see those men who have had their prostates removed in their 70s and now incontinent and have no erections. And you think to yourself, oh, well, maybe we shouldn't have done that operation. You're completely affected by what you see, anecdotal evidence of what you see. And it's all about risk management and having a good, healthy, honest chat with your patients about what it means to go through investigation and treatment for prostate cancer.
Yeah, and I think just in terms of that treatment, I feel like one thing's pretty certain. If you're young and healthy and you've got aggressive disease, you should most likely go for a surgical option. Is that right?
Yeah. Look,
tough question. Just to throw you into the coals.
That would be probably my look. The diplomatic answer is it's an informed discussion with your patient about the risks and benefits of both approaches. Both radiotherapy and surgery offer curative options that are both equal. Men who are younger and fitter and healthier tolerate surgeries much better. They have better continence outcomes, they have better erectile function outcomes, and it offers a very quick and fairly quick way of treating your prostate cancer. And in my experience, most young men opt for an operation and most men who have a few other things going on opt for radiotherapy.
Perfect, mate. Is there anything else we missed that you want to touch on? I think we covered heaps.
Yeah, no. Look, what I'd like to say is that we're supremely lucky in Australia in that we're cutting edge in a lot of things, especially in urology. MRI scans publicly funded by the government is not happening in most places in the world. From July 1, PET scans for prostate cancer are now publicly funded by the government. That is nowhere else in the world. And those are scans that cost 800, $900. Like, this is not easy money. And this is money that, people work hard and can't afford for attending appointments, let alone having these incredibly important scans. Prior to PET scans, we did CT scans and bone scans, which we know were inferior, but we weren't able to do anything better because they cost so much. And we are leaders of that. PET scans in Australia for prostate cancer first came out in 2014. I did a lot of my research at the Wesley and the Royal Brisbane for PET scans, and they were one of the earliest centres to start that. And 9 years later, and now it's Medicare funded or MBS funded, and it's a game. It really is a game changer for treatment for prostate cancer or staging of prostate cancer and management moving forward. So rest assured that a lot's being done in this space. We don't want to take your prostates out unless we really have to. There's lots of treatment. Even, it's not all doom and gloom. Even if you have prostate cancer, that's not curative. We have lots of treatment options for cancer that may have spread into the lymph nodes and the bones and things like that. And it's one of those cancers that's being heavily researched, and Australia is a forerunners in terms of that research throughout the world.
Yeah, that's amazing to hear that, mate, and thanks for sharing that with us. It's one thing that I sort of took from that book I was telling you about earlier, The Organised Mind, Daniel Levitin, talking about urologists, and he wasn't targeting urology, but he just used it as an example.
Yeah, of course.
Just from reading it, it felt as though he was suggesting that we were sort of just doing all these procedures sort of mindlessly and not really understanding the risks. And just to reassure everyone, it's just we are constantly reevaluating. We're constantly looking at ourselves. That's the beauty of science. If someone comes along with evidence and says, "Hey, you're wrong," we go, "All right, let's change."
Yep, exactly right. We don't want to intervene unless we really have to. And those are conversations I have every day with a patient who comes in. Surgery is a last resort at every stage. We don't want to do operation unless we really, really have to. We understand the risks. We're the ones who see you afterwards to deal with those risks, and you're the patients that we hear complaining to us about it. And we hate seeing that. That is the worst outcome for us, and we feel that very strongly within ourselves, as I'm sure you experience as well, Andy, when you put sleep and they don't have that great an experience. But we are doing our best, and we're learning every day. And we're not resting on our laurels, and we'll keep working for our patients as long as we can.
Shell, thank you so much, mate. It's been awesome.
Not a problem. Thank you so much for having me, Andy.
Absolute pleasure.
See you, mate.